Welcome back, future doctors. Today we're breaking down a high-yield topic, abdominal aortic aneurysm, or AAA. This is an exam favorite and also a life-threatening condition in real practice. Let's go step by step. Risk factors, clinical features, diagnosis, and management. Abdominal aortic aneurysm is 4 times more common in men than women. About 5 to 10% of men over 65 years have an abdominal aortic aneurysm. It is often associated with other peripheral aneurysms like femoral or popliteal. Think of an elderly male with severe abdominal or back pain, radiating to the groin. That's a red flag for a ruptured abdominal aortic aneurysm. Most patients are asymptomatic and the aneurysm is found incidentally, but when symptomatic, you may feel a pulsatile abdominal mass. If it's tender, it suggests an impending rupture. Other unusual presentations include atheroembolism to the legs, thrombosis causing sudden limb ischemia, high-output heart failure from an aortocaval fistula, or even GI bleeding from an aortoenteric fistula. Now, how do we diagnose it? Ultrasound is the best screening test. CT scan is the investigation of choice if surgery is being planned. It tells us size, extent, and iliac involvement. Angiography is not used for diagnosis because it can miss the aneurysm, but it is done preoperatively if renal, mesenteric, or peripheral occlusive disease is suspected. For a suspected rupture, the best test is a non-contrast CT scan. Management depends on the size and symptoms. If the diameter is 5 to 5.5 centimeters, if growth is more than 1 centimeter per year, or if the aneurysm is symptomatic, repair is indicated. Treatment options are open surgical repair, which is more durable but has higher perioperative risk, and endovascular repair, which is less invasive, has lower early mortality, but requires lifelong follow-up due to complications like endoleak. Complications of open repair include myocardial infarction, ischemic colitis, and renal failure. In endovascular repair, the big concern is endoleak or graft migration. Prognosis depends on whether it's ruptured or elective. Ruptured abdominal aortic aneurysm. Most patients die before reaching the hospital, and even with surgery, survival is only about 50%. Elective repair has a perioperative mortality of around 5%. Endovascular repair is safer initially, but needs long-term monitoring. Here's your golden pearl. The most common misdiagnosis of ruptured abdominal aortic aneurysm is renal colic. So always think of abdominal aortic aneurysm in an elderly male with new-onset severe back or abdominal pain. That's it for today. If you found this helpful, don't forget to like, share, and subscribe for more high-yield surgery topics. See you in the next video.